Hi, welcome to this episode of Patient Education for the Educated Patient. In this episode, we're going to talk briefly about the introduction topics to a trial of labor after cesarean section versus undergoing a repeat cesarean section. So this video is specifically for patients who've had a history of a C-section and they're trying to decide what to do and how to have this baby the safest way possible for subsequent pregnancies. So let's start with the take-home points, just 2 take-home points. Number 1, if you've had a previous cesarean section in the lower uterine segment, then you may be a candidate for a TOLAC in hopes of achieving a VBAC. And that stands for trial of labor after cesarean section and a vaginal birth after cesarean section. As you can see, this is just an introduction to the topic of trial of labor after C-section and vaginal birth after C-section. And it already gets fairly complicated very quickly. So that's why the decision between a TOLAC and a scheduled repeat C-section needs to be made together with your obstetrician. So a little bit of history. For a long time, the assumption was if you've had a C-section, you should always have more C-sections. Now that could be based on several things. Number 1, nobody really knew what would happen if you got pregnant again and you were in labor. For a while, if you had a C-section, you were told never to get pregnant again. And before, the original C-sections were done with a vertical incision on the uterus instead of a transverse incision on the uterus. The vertical incision on the uterus was at risk for uterine rupture even before going into labor. So it was a much more high-risk C-section to have had. And so that may have played a role in the idea that once you've had a C-section, either don't get pregnant or always have more C-sections. But that started changing. And in 1981, the National Institute of Health held a conference addressing this specific issue in an effort to increase trial of labors after C-section. And in 1988 and 1994, ACOG came out with written decisions in support of TOLACs. And as a result, the vaginal birth after C-section rate rose dramatically from only 3.4% in 1980 to 28.3% in 1996. So visually, you can see that here. Vaginal births after C-section are depicted in this red line here. And you can see that they peaked in the late 1990s. And as with all things in medicine, they probably followed this pendulum effect where we didn't do any vaginal births after C-section. Then we started doing a bunch of them until we did too many, saw a bunch of complications, backed off. Then they got too low down here, saw too many complications from scheduled repeat C-sections, patients that were having 3rd, 4th, and 5th C-sections. So then we overreacted and the pendulum swung in the other direction. So you can see how the trend over time is not only going to influence the decision-making process, the success rate, and the literature surrounding trial of labors after C-section, including rupture rates, success rates, etc. One of the things I wanted to bring to your attention is that in 1998, ACOG had wrote, the physician should be readily available. Then in 1999, ACOG had changed readily into immediately available. And as a result, the vaginal birth after C-section rate started going down dramatically because in the late 90s, a lot of physicians were taking call from home. And so by the time they got there for an emergency delivery, the damage was done. The uterus had ruptured and complications of the uterine rupture had already occurred. One of the other responsibilities for this uptick in the 2000s is probably because of a growing adaptation of labor and delivery units to hire laborists or hospitalists to staff labor and deliveries 24/7, 365, so that they could have patients undergo trial of labors after C-section in a more safe, controlled setting so that they could always intervene with the in-house attending and deliver these babies emergently if the need arose. So here's another depiction of the percentage of patients undergoing a trial of labor after C-section. Again, the number of people undergoing a trial of labor after C-section peaked in the late 90s and is depicted in these blue dots. And then it went all the way down and natered about 2005 and started seeing an uptick once again. And the red dots was the success of vaginal births after C-section. As you can see, we got steadily better at performing vaginal births after C-section, but after the number of patients undergoing a TOLAC went down, well, the success rate for vaginal births after C-section went down as well. And that's very intuitive. The more you do something, the better you are at it. And as we started doing less of it, we started not being as good at it or having a lower threshold to throw in the towel and go ahead and deliver that baby by C-section. But it's the hopes that as TOLACs become more popular, that our VBAC success rate will also mirror that, even if it lags behind a little bit. So let's talk about the risks for the mom. Everybody wants to know, what are the risks to the mom and the baby when it comes to delivering a baby having had a previous C-section? So looking at just the mom, we're comparing a scheduled repeat C-section to the group of patients who underwent a trial of labor after C-section. So you have to remember, the TOLAC arm is going to be comprised of approximately 70% VBACs and 30% of patients who ultimately underwent a cesarean section while they were in labor. And you can see here the most important figure that stands out is a 0.7% uterine rupture rate when undergoing a TOLAC. And that's the uterine rupture rate. That's the one thing that everybody's nervous about when you're undergoing labor, having had a previous incision and scar on your uterus, is that incision and that scar may open up as the uterus is contracting or that you're trying to deliver a baby. And that can become quite the emergency. The other thing that's important to pay attention to is maternal death. Maternal death is actually 5 times, more than 5 times higher in the scheduled C-section arm than in the trial of labor after C-section arm. And you can imagine why. In one group, you're having approximately 30% of patients undergo a cesarean section or major abdominal surgery. And in the other arm, you're having everybody undergo abdominal surgery. So that likely accounts for the higher maternal death rate in the scheduled C-section arm. And keep in mind, this is just history of one cesarean delivery, and that will only get higher if you've had 2 previous C-sections, 3 previous C-sections, etc. So now let's talk about risks to the baby. Now, a lot of patients want to do what's best for the baby, but that's a very hard question to answer, because if I had to generalize the outcomes of the baby, the successful vaginal births after C-section are going to have the best outcomes, followed by probably the scheduled C-section deliveries. And then ultimately the worst outcomes are going to be the babies that labored, tried to deliver vaginally, and then ultimately were delivered by C-section. So the groups 1, the VBACs, and group 2, the failed TOLACs, which deliver by C-section, those are all going to be lumped together in one arm. And that's going to be compared to the second best outcome, which is a scheduled C-section. And that's why there's going to be a lot of overlap and variabilities in the outcomes, and it makes it very difficult to compare these averages. But nonetheless, intrapartum stillbirths is the number of babies that died during delivery or labor and delivery. And you can see that it's at least 10 times higher in the TOLAC group. You're also going to have a higher risk of hypoxic ischemic encephalopathy. And what that is basically brain injury to the baby due to lack of oxygen. The perinatal mortality, the neonatal mortality are both higher. And so these are all things to keep in mind. But remember, The TOLAC group is made up of patients that had successful vaginal births after C-section and babies that were delivered by C-section after a failed TOLAC, which is going to be much higher risk and probably accounts for a majority of the adverse outcomes for babies. So let's talk about who are eligible candidates. Most women with one previous cesarean delivery with a low transverse incision are candidates for and should be counseled about and offered TOLAC. And so all of these statements are directly copied and pasted out of the ACOG practice bulletin. And I just want to reiterate that because this is not my opinion. This is just ACOG's opinion. There's multiple opinions. Everybody has their own data and their own conclusions, but our society will differ from like the Canadian Society of OBGYN or the United Kingdom Society of OBGYN. So it's going to differ slightly, but these are directly just from ACOG. So who else is an eligible candidate? Patients who have had 2 previous low transverse C-sections are also candidates to undergo a TOLAC. And the reason for that is you do have a higher risk of uterine rupture with more C-sections, but after 2, it's still appreciably low at about 1 to 1.5%, depending on which study you're looking at. What about unknown uterine scar? You had a history of a C-section, but you don't know how they did it. You can't get the operative report, can't get it from the hospital, can't get it from your old doctor. It's in a different country. Well, ACOG says that since a majority of C-sections are done in a low transverse incision type of fashion, that even if you have an unknown uterine scar, it's safe to undergo a trial of labor after C-section, unless there's a high suspicion that your C-section was done via a vertical incision or a classical incision high up in the fundus. Those patients have an increased risk of rupture that preclude them from having a TOLAC. But if you have an unknown scar and you're relatively certain that it was low transverse, you are a candidate for a TOLAC according to ACOG. But also keep in mind, when studies looked at unknown uterine scar types, they did have a higher risk of uterine rupture. Again, somewhere between 1 and 1.5%, and not that 0.5 to 1% that you see with documented low transverse C-sections. And what about low vertical uterine incisions? This is a pretty rare C-section to do, but every once in a while you'll have a patient who had a previous documented low vertical uterine incision. So these patients are candidates for TOLACs according to ACOG. However, they do stress that there's no good data to support a higher risk of uterine rupture, but there's also no data to really support that there is a very low risk of uterine rupture. What if you have twins during this current pregnancy, but you've had a history of a C-section? Well, as long as you have no other reason you can't or shouldn't deliver these twins vaginally, then a history of a C-section would also not preclude you from undergoing a trial of labor. So if you've had a history of a C-section, you can try to deliver twins vaginally in a subsequent pregnancy. I briefly talked about the ineligible candidates, or the patients who should not undergo a trial of labor. And these include patients at very high risk for uterine rupture. That can be classical uterine incisions, T incisions, prior uterine rupture, or any extensive transfundal uterine surgery. That typically means myomectomies or fibroid surgeries, and sometimes septoplasties, where you're removing septums out of patients' uteruses which have Müllerian anomalies. And finally, anybody who has any other contraindications to a vaginal delivery obviously shouldn't undergo a TOLAC either. All right, you had a history of a C-section. This pregnancy, your baby is breech. It's full term or close to full term. You want to undergo an external cephalic version. Then that is safe. ACOG states that there's no reason why you can't undergo an external cephalic version when you've had a history of a C-section. There's no data to say that there's going to be a higher risk of rupture with the external cephalic version or trial of labor. Now, what about induction of labor? Induction of labor itself is not a contraindication to a trial of labor after C-section. The tricky part when it comes to induction of labor is associated with a higher uterine rupture rate, but that may be only attributable to cervical ripening with Cytotec, because there are some studies showing higher risks of uterine rupture with Cytotec. There are some studies saying Cervidil is safe. However, because it's in the same family as Cytotec, a lot of doctors are going to shy away from using Cervidil with a history of a C-section. So that really leaves just Pitocin for induction, or possibly a mechanical dilator such as a cervical Foley balloon, a Cook Foley balloon, or some trans-cervical mechanical dilator of the cervix. And ACOG also recommends all patients undergoing a TOLAC have continuous fetal heart rate monitoring. That means no intermittent monitoring, no NSTs, just Q hour. Really, you should monitor the baby's heart rate the entire time, because the abnormalities in the fetal heart rate tracing will be the first sign that something is going wrong and that you're rupturing your uterus. And that's why ACOG recommends continuous fetal heart rate monitoring for anybody undergoing a TOLAC. And some doctors will take this one step further. They'll actually want a fetal scalp electrode on, which is going to monitor the fetal heart rate continuously better than an external Doppler. The external Doppler that sits on top of the mom's belly, well, that can lose the baby's heart rate when the baby moves, when the mom moves, when you shift position. For any number of reasons, you can lose contact and lose track of the fetal heart rate. But when you have a fetal scalp electrode on, that's a wire that goes through the vagina, through the cervix, and physically makes contact with the baby's scalp or skin directly, and that can record the fetal heart rate no matter what position you're in, no matter if the baby's moving or the mom's moving, no matter what the heart rate is it up, is it down? It's not going to lose the heartbeat like an external fetal heart rate Doppler has the potential of doing. So again, the most common and early sign of a uterine rupture is going to be abnormal fetal heart rate patterns. And that's why continuous fetal heart rate monitoring is so important. All the other signs of uterine rupture are going to happen later, possibly too late to make any difference in the outcome for the pregnancy or the baby. And that can include vaginal bleeding, loss of station, pain, not responsive to pain medicine or epidural. By the time you're having these symptoms, the uterine rupture might have already happened, or the damage is already done and it may be too late to intervene. Only the fetal heart rate is going to give you the possibility or even the chance to detect something going wrong before something catastrophic happens. And that's why monitoring the fetal heart rate continuously is so important for patients undergoing a TOLAC. Now, the facility, ACOG specifically says that TOLAC should only be performed in facilities that can provide a cesarean delivery. So that excludes home births, that excludes birthing centers, and they really recommend only facilities that can deliver by C-section and immediately, respond immediately to life-threatening situations for mom and baby. So they don't specifically define what kind of facility should be required for a trial of labor after C-section. But if I were you, I would make sure that the hospital you're delivering at has in-house obstetrician 24/7, residents at the least, but in-house attendings or board-certified attendings if you can. You want to make sure there's anesthesiologists 24/7. You want to make sure there's surgical techs, nurses, ORs available 24/7 if you're going to undergo a trial of labor after C-section. Really, the more people there in the hospital 24/7, the safer it's going to be. Now, the decision and consent process, ACOG again says that this should be made by the patient in consultation with her obstetrician. And this is either going to be called joint decision-making or shared decision-making, but there's pros and cons to a trial of labor after C-section versus scheduling another C-section. That's why ACOG has a stance that patients can pick and choose what's best for them. And that decision needs to be made in consultation with their obstetrician. So hopefully this video will help. I also made a video about a VBAC calculator that can stratify your risk of a C-section undergoing a TOLAC and your chance of delivering vaginally if you undergo a trial of labor after C-section. So that will just add a little bit more information to your decision-making process so that you can make the best decision for you, your baby, your pregnancy, and future pregnancies when you're faced with this decision and you've had a history of a C-section. So again, hopefully that helps. It's not meant to be comprehensive. It's really only meant to make sure that you know you have the option of having a TOLAC in the hopes of delivering vaginally if you've had a previous C-section in the lower part of the uterus, the non-contractile portion, whether it's one C-section, two C-sections, an unknown scar, or even a vertical incision in the lower uterine segment. These are all candidates for a vaginal birth after C-section or a TOLAC. The final thing is that deciding between a TOLAC and a scheduled repeat C-section needs to be made in conjunction with your doctor. Again, it's a complicated decision. This video itself already got very complicated, and we're only touching on the very basics and only trying to introduce you to some of these concepts, these risks, these benefits, and these alternatives to delivering vaginally versus delivering by a planned C-section. So again, hopefully it helps, gives you a little bit of foundation of knowledge, a little bit of confidence so that you can go into your doctor's office and have an educated decision about what to do for you and your baby and your pregnancy and even your next pregnancy. So hopefully that helps. Hope to see you at the next video. In the next video, we're going to address the informed consent process when it comes to a trial of labor after C-section. So I hope to see you at that episode. There'll be a link at the end of this video. Until then, stay healthy and stay educated. Thank you for watching this episode of Patient Education for the Educated Patient. I hope you found this content both helpful and meaningful, and that you'll be able to use it to live a healthier life. If there's any questions, please leave them in the comments section below. I do welcome feedback, so please also leave me any comments or suggestions in the comments section. Please subscribe and turn on the notifications, and I hope to see you at the next episode. Until then, stay healthy and stay educated.